Hello everyone, my name is Claire Nightingale and welcome to this session on routinely collected data, which is part of the quantitative data collection block. Routinely collected data are, as the name suggests, information that are collected routinely. It can be for a number of reasons that the data are collected. Data are collected in organisations such as the NHS for a number of reasons. Research is only one purpose of routinely collecting healthcare and demography data. In England, hospitals provide statistics on episodes of care so that they can be paid by those who commission their services. General practice payment structures are also reliant on what they do, not just who their population is. The provision of information of births and deaths in England is a legal requirement, as it is to notify the proper authority. And the census is also a legal requirement to complete. Households can be fined if they don't complete a census form in lots of countries, for example England and Wales and the United States. So the pros of using routinely collected data include that it is collected on a large scale, it is relatively cheap to obtain, there's usually a good level of completeness, it provides information where not possible or even ethical to collect directly, for example where the patients have died. The data are contemporary and information is recorded at regular intervals so can be used for following trends. The cons include that it is rarely 100% complete, so it is important to consider missingness in your data. They can become quickly out of date and you may need to keep applying for updated data, so you may need to take this into account in the time taken to apply for the data. Changes in the methodology of data collection can occur, and most importantly, the data have not been collected for your particular purpose, so they may not include all of the information that you need for your purpose in the format that you need. When considering whether routine data are suitable for your purpose, i.e. your evaluation, it is important to ask, what proportion of the data are missing or incomplete? For example, if you are using the Quality and Outcomes Framework registers, or QOF registers, to estimate the percentage of the population with chronic obstructive pulmonary disease, you would miss the percentage of the population who do not have a primary care diagnosis. In some areas of England, QOF registers comprise of just 30 to 50% of expected cases, so those diagnosed in settings outside of primary care. It's important to consider the accuracy of the data. Are there mistakes or other reasons for inaccuracies in the data? For example, approximately 10% of hospital episode statistics data have coding errors according to sources. However, this has improved since the introduction of payment by results. Consider what else might improve or reduce the accuracy in routinely collected data. For example, are there rules in place in the data entry system that would prevent data which don't make sense being entered? For example, systolic and diastolic blood pressures round the wrong way. Also consider the relevance of the routinely collected data. To what extent are the data what you need to know? For example, area deprivation indices will describe generic area characteristics, but they won't tell us about individual level deprivation. And finally, also consider the timeliness of the available data. Have things changed since the data were collected? For example, the census is only collected once every 10 years in England and Wales. If you were using this data, would it still be a good reflection of your local population 8 to 9 years after collection? So that concludes our session on routinely collected data. Thanks for listening.